Good morning, everyone, and welcome to the annual Sentinel Public Training. My name is Noelle Cocoros. I'm an investigator with the Sentinel Operations Center at Harvard Pilgrim Healthcare Institute, and I'm very happy to be facilitating the morning and to also be giving one of the talks. Before we jump into the material and get into some other of the housekeeping, I'd first like to welcome Dr. Gerald who will be providing some opening remarks. Dr. Delpan is the director of the Office of Surveillance and Epidemiology in the Center for Drug Evaluation and Research at FDA. Thank you, Dr. Delpan.
Thank you, Noelle, and welcome to everybody to today's Sentinel training. I'm Gerald Delpan. I'm the director of the Office of Surveillance and Epidemiology. I'm the executive sponsor of Sentinel at FDA, and it's a program I, along with many of my colleagues, both here and in Boston and amongst our data partners, have been involved with now for roughly 13 years. And so it's been a very rewarding journey we've taken here. It's gratifying to see how far together we've all come in this. Today's training is part of an ongoing series of training that was begun some years ago. We've had training on descriptive analyses, inferential analyses, a tree scan for signal detection. And now we want to introduce our mother-infant linkage and pregnancy analyses, as well as some propensity score analyses that can be done within those. So this brings together two important initiatives for the agency. One is, of course, our commitment to Sentinel and our commitment to real-world data and real-world evidence. And the other is our commitment to maternal and child health. I think, as some of you know, we have a very active maternal and child health program here. And today's training, in fact, our further development of Sentinel over the past few years to include mother-infant linkage reflects our commitment to that aspect of public health. So I know you have a very busy training session, and so I don't want to take any more time. So I'll turn it back over to Noelle. Thank you.
Thank you, Dr. Delpan, and welcome everyone again. This is Noelle Cocoros. I'm an epidemiologist and investigator in the Sentinel Operations Center at Harvard Pilgrim Healthcare Institute. And what I'll do before I jump into the training aspect that I'm going to give, Liz, if you can go to the next slide. I figured I'd first just walk you quickly through the agenda. So I'll be providing really a very big picture overview of what the Sentinel system is and a broad overview of the range of our analytic capabilities. The next 2/3 of the morning will be focused on pregnancy, as Dr. Delpan said. So Dr. Elizabeth Suarez, who's a Sentinel Fellow in the Harvard Pilgrim Healthcare Institute, will be talking about the ability to create a mother-infant linked cohort for descriptive pregnancy analyses. And then Dr. Mayura Shinde, who's another investigator in the Sentinel Operations Center, will be talking about the inferential analytic capabilities for perinatal exposures using a particular use case. And that's, we'll be coming back to this, both Liz and Mayura will be describing this use case that is the examination of topiramate use in early pregnancy and risk of oral clefts in infants. Let me just give you a little bit more detail and housekeeping on the structure of the morning. So before I get started, we'll do a very brief pre-training survey rather, to just get a rough sense of where people's current understanding lie before we go ahead with the training. I'll speak giving this big picture overview. Then Dr. Suarez will give her talk. We'll take a 10-minute break, and then Dr. Shinde will come back for the last session in this morning. And at the end, we'll do a post-training survey. So a couple of other notes is that I mentioned this in the chat box, but please use the chat box to share any questions that you have. Our colleague, Dr. Judy Morrow, who's an investigator in the Sentinel Operations Center, as well as others, will be monitoring the chat box and responding as needed throughout our talks. We've also built in, hopefully, a few minutes at the end of each of our specific talks to answer any questions that remain. The slides all will be posted publicly, and everyone who's registered for this session will, or for the training rather, we'll get an email with a link to the slide. So no need to worry about taking very detailed notes. And then finally, as I mentioned in the chat box as well, there's a closed captioning option. So if you'd like to turn on closed captioning, if you hover towards the bottom of your screen on the right-hand side in the middle, there's a closed captioning button. And the training will be recorded today as well. So I guess at this moment, I'd like to turn it over to Yulia Salo to please open up the pre-training survey. And if everyone can please answer these few quick questions, it would be really helpful to us. And hopefully everyone is seeing the pre-training survey now. And once that's complete, I'll come back and we'll get started with the training itself. All right, Yulia, I'm seeing a comment that at least one person's not seeing the survey. Hopefully others are able to and are able to complete it. We're going to wait just a few more minutes. Yulia, is there any technical guidance we could give to anyone who's not able to see it?
It may be your Zoom. You should, I would try to see if you have any other windows that popped open. So if you have it in full screen, you occasionally may not be able to see it. So I recommend minimizing your Zoom and maybe you'll show up there.
And thank you. I know that a number of people are currently submitting. So thank you for those who have, or just wait another couple minutes. And anyone who's continuing to have difficulty, I'm sorry about that. It might be that if you have pop-ups blocked, that might also be getting in the way. All right, we'll just wait another couple minutes. All right, well, thanks everyone. Thank you for completing that survey. It was brief. I'm sorry again for anyone who wasn't able to. I was really just asking about what type of organization you worked for, what your role is, and if you have a sort of substantial understanding of Sentinel or not. It was a very brief, trying to get a very brief sense of who our attendees are. So Liz, if you can move to the next slide. Actually, I think you can advance 2 more. All right, next one. All right, so thanks everyone and welcome again. My name is Noelle Cocoros. I'm going to be giving the first third of the training, and really this is a broad, high-level overview of what the Sentinel system is. And Liz, if you can go to the next slide. So I'm really going to give sort of everything from what is conceptually Sentinel, what are the sort of underpinnings in terms of data philosophy that are employed for Sentinel, how is the network developed, and what are the key aspects of it. And then a good chunk of the time will be spent talking about what are our analytic capabilities. And then finally, how can you get access to those analytic tools? So those are the major components of what my session will be focused on. So the Sentinel system, which sits within the Sentinel initiative at FDA, is focused on giving FDA the ability to assess the utilization, safety, and effectiveness of medical products, vaccines, and medical devices. So it's one of the many tools that FDA has to do its job and is heavily rooted in the use of real-world data. This slide gives you some of the really core concepts of what the Sentinel system entails as an active surveillance system. So on the left-hand side in that orange colored box, this gives you just basically a few words on how does the Sentinel system work. So Sentinel is comprised at this time primarily of insurance claims data in the United States, so administrative claims data, some electronic health records, and some other data sources as well. We use, you can see here, computer programs. I'll also be using interchangeably analytic tools or analytic capabilities, which are computer programs, to be able to conduct analyses. And so it's really rooted in real world data and the use of these computer programs to conduct analyses. And there are many questions that FDA can use the system to answer. So in blue, there's some example questions here, and I'll be talking about this a lot more later as we go through the analytic capabilities, putting it all in the context of what is your question or what is FDA's question. In the purple box, it's important to note that in terms of privacy and patient confidentiality, there's no identifiable information that leave the data partners themselves. And I'll be talking a lot more about that in a moment, but it's a really core aspect of what Sentinel is and how we function. And on the right side in the red box, you can see a brief summary really at the very highest level of what happens after FDA conducts one of these analyses in Sentinel. And as I'll talk about a little bit later, it can be used to inform advisory committee meetings. The data from Sentinel analyses can also be used to develop drug safety communications, inform label changes, et cetera. So there are many different ways that FDA uses the results from analyses conducted within Sentinel. And importantly, a lot of information on that particular aspect of Sentinel, but then more broadly, really a lot of the underlying capacity of Sentinel is on the Sentinel website. So the Sentinel website is sentinelinitiative.org. If you go there, you can learn a lot about how the data are organized, who the data partners are, many examples of how FDA has used results from the Sentinel system, and all of the reports that have been generated as a result of analyses conducted within Sentinel. So if you go to the next slide, I'm going to walk you through the underpinning of what the Sentinel system is, which is a distributed data network. So for many people on this training, you know what this is, but I'll walk through it just to make sure everyone's on the same page. So at the root of this, what it means is that we have a number of data partners, and we use that phrase very explicitly, and I'll talk about it more later, in that they're data partners, they're not just data sources. But we have many different data partners, and I'll talk about who they are in a moment. They transform their data, again, primarily insurance data, administrative claims, into a data model so that for all intents and purposes, from the Sentinel system's perspective, the data look the same. And we can then send out a computer program or analytic tool to run against those data. So we distribute, so we as the Sentinel Operations Center, write these computer programs. We distribute these programs in an encrypted and secure way to the data partners. They run the analyses on their data. And then you can see on the far right-hand side, that little blue box, the results get returned to us at the Sentinel Operations Center in a secure way, generally aggregated, no individual level data. We then, in the Operations Center, aggregate further across all the different data partners and return results to FDA. So that's really the sort of overview of what the distributed data network is. On the left-hand side, you can see reference to the common data model, which I'm going to talk about in a moment. A couple of things to note is that, as I'll show you, the Sentinel data partners are, there's an enormous range in who they are and the type of data that are available. And the size of the system, as I'll describe, is large enough to enable FDA to study rare adverse events and drugs that are not used very routinely. The other thing to note, and really this is the reason why we're doing this public training, is that all of our analytic tools, which were developed mostly for FDA to be able to use the system, are also publicly available. And so anyone, any organization that has taken their own data and transformed it into a Sentinel Common Data Model can use these tools as well, which is what we'll be talking about throughout the morning. So on the next slide, Liz, if you wouldn't mind, the Sentinel organizations are listed here. So these are all the collaborating organizations. So we at Harvard Pilgrim Healthcare Institute are the Operations Center. And then the bulk of this slide, which is, you can see many different organizations listed here. We have basically two categories. So one is partners who are both data and scientific partners. So those are organizations that include their data in the Sentinel Distributed Data Network, and then also, and so we run analyses including their data, and then they're also scientific partners as well. And then we have colleagues at other organizations who are just scientific partners. So they come in and work with us and FDA to design studies and conduct analyses within the Sentinel system. And it's important to note here the enormous range of organizations on this slide. So the Sentinel system at this time is primarily administrative claims data from organizations such as large national health plans. So you can see HealthScore and Humana and Optum are listed here. We also have integrated delivery systems, such as Kaiser Permanente sites. And then importantly, we have data from CMS via colleagues at Duke for the Medicare fee-for-service data. So everything from Medicare through small integrated delivery systems that include EHR data to very large national health plans. On the next slide, I'll talk a little bit over the next couple slides about the Sentinel data philosophy. So if you can advance, I think one or two more, yeah, perfect, right there. So as I mentioned, the data at this point is predominantly claims data with some electronic health record data, as well as capability to bring in registry data as needed. The data model is developed with enough flexibility, as I'll talk about, to be expanded as needed. So we can add in new data domains and really different types of data elements, including free text. And I'll talk about this a little bit later, but really the data partners populate the tables as makes sense for them. So it's really fit for purpose in terms of the type of data they have and which part of the data model they populate. The data themselves and the data model, the way it's defined, is to enable us to store data at the most granular or raw level possible with really minimal mapping. And so what that means is, for example, one, we have both prescriptions and dispensings, but also if you wanted to study diabetes, you may develop an outcome algorithm for that that is based on diagnosis codes or multiple diagnosis codes or treatment or procedures. But we don't necessarily have that diabetes algorithm stored in the common data model. We have the diagnosis codes and the procedure codes. And so there's enormous flexibility in what we're able to study. But then, of course, these algorithms that we use are stored for future use. So if you go to the next slide. And then there's some really important concepts here, although in very brief language, I think it really gets at so much of how the Sentinel system has been designed and implemented, is that the data partners, again, using that term very explicitly, are really part of the system, not just as data providers, but they bring their knowledge and expertise of their own data, not just to help us understand what their data look like and how to use it, but also how to interpret results. They also populate tables that are appropriate for the types of data that they have. And as I mentioned, really, this whole system has been designed to enable flexibility and transparency. And that's a really important part of what the Sentinel system is. So again, it's part of why we're here today, is to help you understand what's available to the public through the Sentinel website, both in terms of analyses and their results, as well as the tools themselves. And then the control is maintained within the data partners. So they keep all of their data behind their own firewalls and run analyses after they look over what we've sent and confirm that it's appropriate for them to be run, and then release their results to the Operations Center and FDA for aggregation and further analysis. So if you can go to the next slide, I'm going to talk now about the Sentinel Common Data Model, and I'm certainly not going to read all of the different data elements on this slide, but I really want to just orient you to how the data are captured in the Sentinel Common Data Model and what components are there. So there's a group of data elements that are under the heading of administrative data. So those include things like, importantly, enrollment. So again, because we're predominantly insurance claims data at this time, what that means is we have very concrete start and end dates for someone's period of time that they're in the system. We also have information on their demographics, on all the encounters they've had in terms of what's been billed to their insurance. So inpatient, outpatient, ambulatory. And then dispensings. So this is an important point, that this is dispensing data, not prescription data in this context. And it's predominantly outpatient dispensing data. So that means someone has actually filled a prescription. We have diagnosis codes and procedure codes. There's also two tables that get at clinical data. So lab results and vital signs, and those generally come from electronic health record data, not always, but particularly the lab results can also come from claims data as well. On the bottom left, you can see registry data. So we have the capacity to bring in data from a few different types of registries. For example, in the past, when we've conducted vaccine safety analyses, we have the ability to bring in state vaccine registry data, as well as death and cause of death. We have a couple of tables that are specific to the inpatient setting. These are generally not populated by most of our current data partners at this time. And those include inpatient pharmacy data in terms of administrations of drugs, as well as inpatient infusion data. And then on the bottom right-hand side, I'm not going to talk about this too much because Liz is going to spend a lot of time on this. We have the mother-infant linkage table, which is the linkage between a woman who has had a live birth delivery and her infant, so that information about both can be included in the same analysis. So if you go to the next slide, I'm going to walk you through an example person. This is a fake person, and it's really, again, not going through all the details, and there's a lot of labels here for different data elements, but to just give you some basic details about how this works. So if you click to the next slide, you can see here the demographic information. So this is a female who was born in 1984, who, if you click one more time, had an inpatient encounter. So you can see on the right-hand side of this row, it says ENC type, that's encounter type. And it's an inpatient one. So in October 2005, this woman had an admission on October 18th. And if you click ahead, you can see that during that inpatient or that hospitalization, this person had a number of different diagnoses that were captured. And you click again, you can see that there was also a procedure during this inpatient encounter. Now, what you also see, if you click one more time, is that there were a number of dispensings that this woman had in this period of her enrollment in insurance, where they were dispensings both before and after her inpatient stay. And so you can see here some examples there. And then finally on the bottom, you can see this woman had a baby, had a pregnancy that resulted in a live birth delivery, and she was linked to her infant. So again, this is a fake person with fake dates, but it gives you a sense of how the data are captured and organized and then available for use for analysis by our different analytic tools. So that's really a very big picture overview of what the Sentinel Common Data Model is. And now I'm going to give you an overview of what happens when data partners put their data into the common data model. So there is a robust quality assurance and review period where every single time a data partner updates their data, we work with them, we being the operations center, work with them to ensure that their data look and are performing as expected. So I won't walk through all of the steps here, but what you can see is that if you start at the top left-hand corner where it says preparation, we at the operations center will develop what we call our QA package. So we develop a set of computer programs that the data partners will run on their data every time they update their Sentinel data. So Sentinel data partners can update their data. There's actually a range of frequencies. So some update only annually, some update quarterly. And every time they do that, they run a set of packages to check the data. And we work with them through that process to ensure that all of the expectations are met. So as you can see on the top right in that little blue box, there are more than 900 different checks that are run, and a number of flags will be created by the programs that say, essentially, they're a trigger to the data partner to go and investigate this issue and to work with us to ensure that anything that needs to be resolved does get resolved. And this is an iterative process whereby we work with them to understand the flags, identify what may be going on, but ultimately the data partners, as the owners of their own data and who know their data best, work through this process to ensure that everything works as expected. And in the end, that new refresh of the data gets approved for use, and it goes into what we refer to as production, meaning now when FDA asks a question of the system, that's the data that will be used to answer it. So if you go to the next slide, Liz, this is an overview of the different levels of checks that go on with this quality assurance packages. So the level 1 is sort of the most basic. So this is looking to see, are the data elements complete? Are they in the formats that we expect? Basically, is the common data model being complied to? And then the checks get increasingly complex to some degree. So now we want to check at level 2, accuracy and integrity, meaning when you take information that's captured in multiple tables that should make sense together, or across different variables that they do. For example, an admission date comes before a discharge date for a hospitalization, or we only see admission dates during a time when someone is actively enrolled in insurance. And then lastly, and this is an important point, so every time the data partners update their data, they essentially are overwriting the data that are used for Sentinel for production purposes. Now, much of their prior data gets saved in case we need to go back to it, but for what's being used actively in the system, there's an overall rewrite. And so we want to make sure that there's been no major change from one refresh to the next. So for example, if we're expecting to see X number of admissions generally per month or per year within this partner's data, are we seeing that? Is there anything that looks odd? And sometimes there's a good explanation. Perhaps the organization has acquired another health plan or had a substantial increase in their membership. So we work with them to make sure we understand whether there's either an anomaly or an error in the data, or if there's an explanation for it. So if you go to the next slide, so that's again, this is sort of a crash course in all the major concepts and workings of the Sentinel system itself. So that was the common data model and what happens every single time a data partner refreshes their data in, essentially 1.5 slides. And now what I'll show you is the big picture overview of the size of the Sentinel distributed database at this time. So at this moment, there are 351 unique patient identifiers, and there are about 71 million members currently actively accruing data. So the distinction here between a member and a patient identifier. So my data are in the Sentinel distributed database due to where I get my health insurance from. And so I have a patient identifier. I have an enrollment date. I don't yet have an enrollment end date. But if in 6 months I disenrolled from my health plan and wound up actually being insured by another health plan that's a data partner, I would have 2 different patient identifiers. At this time, we do not link across health plans. So I would be in there 2 separate times with different enrollment start and end dates. So that's the distinction here about patient identifiers. And then the graph that you're seeing, this is giving you a sense of the size of the system over time and how it's grown. So early on in the mini Sentinel phase, which was the pilot phase of Sentinel, we reached the goal of 100 million unique patient identifiers in 2011. And another big milestone to note on the far right-hand side is when the Medicare fee-for-service data were brought in January 2018, and you can see what a large increase that gave us. So that gives you a sense of the size of the system that's available to FDA to study and ask questions. So if you can go to the next slide, Liz. All right, so now, covered what the network is, how the distributed data network works, common data model, QA, and the size of the system. What I'm going to spend a good portion of the rest of the time on is talking about our routine analytic tools or routine analytic capabilities. Again, we use those words interchangeably, and what we're really talking about is computer programs. And this time, at this point, those computer programs are written in SAS predominantly. So if you go to the next slide. So this is to give you some orientation, and I'll continue this, but this is talking about the Active Risk Identification and Analysis System, or ARIA, which is a component of the Sentinel system. And it's used to conduct medical product safety surveillance. And what it includes is the data in the common data model, as well as our analytic tools. And there are 3 levels of tools, as well as a capability for signal identification. So that's what you can see in that schematic. We have the ability to run signal identification analyses to detect new and unsuspected potential safety concerns. And then the rest of our tools are organized in 3 levels. So the first level is descriptive analyses that are unadjusted. Our level 2 is a set of inferential analyses that have confounding control with propensity score adjustment. And then level 3 is when we're doing sequential analyses that have that are adjusted as well. So I'll come back to this throughout, but there are these 3 levels of capability are important to keep in mind. And then what you can see in the text at the bottom is, yeah, thanks, Liz. So the computer programs or tools are really templates. They're very complex templates, but they've been designed to answer a set of questions that FDA asks on a very regular basis, but that have a lot of flexibility. So they can be parameterized based on what the question is, what the question is that FDA has at that time, or what you have if you're using the tools. So they're flexible, they're able to be used very quickly and efficiently once they're developed. You can think of them as off-the-shelf tools, and they've been tested and quality checked before they're made, 1, public to you, for those of you who are external to FDA, and before they're actually being used as part of the system. And they generate standardized output. So we're always going to get the same types of tables and sometimes figures, depending on the tool that you're using. All right, so if you go to the next slide. All right, so this is, I'm going to be referring back to this over the next several slides. And you can see here that at the top of the slide, you see the question, what are you investigating? So all of our tools are categorized in these 4 broad types of questions you may have, or that FDA may have. Are you interested in just medical products themselves? Are you interested in outcomes or conditions only? Are you interested in looking at outcomes following exposure to a particular medical product? Or are you interested in understanding things that have happened over time in the context of an FDA regulatory action? I'll talk about that a little bit later. So on the left-hand side is the medical products only. So, and I'll say actually within these different broad categories of types of questions, you see the level 1, the level 2, the level 3 referred to in the little boxes. So again, within these categories of questions, you may be asking or interested in asking only descriptive analysis with an unadjusted result, or you may want to conduct an inferential analysis or a sequential analysis. So what I'm going to do is walk through most of the capabilities that are listed on here in a really sort of high level way so that you get a sense of what's possible. And really what's intended here is not to make you an expert in any of these. I think you'll get a lot of detailed information from Liz and Mayura about the pregnancy capabilities. But what I'm trying to do is give you enough information that you have a sense of what's possible in the Sentinel system, that you can understand where to go and how to get more information if you're, for example, reviewing a report or a manuscript that includes results from a Sentinel analysis. And then also, you'll also have a sense of if you actually want to use a Sentinel tool, generally, how does it work, what's possible, and more importantly, where to find that information. All right, so Liz, if you can click on the next slide. So what I'm going to start doing is giving you a really big picture overview of each of the different analyses that are possible with an example to illustrate the capability. But really, this is at the highest level, again, just giving you enough information so that you have a broad working understanding. So the first capability, and perhaps the most simplistic, at least conceptually, not so much in terms of the output, quite frankly, but really conceptually, is if you want to understand the utilization of a particular medical product. So we have levels of analysis, but then we also we name these by different types. And I'm going to show you a little bit later where to find documentation on these different analytic tools. And you'll see reference to these types as well as the name of the capability. So this is what we call our type 5, but really just think medical product utilization. And so what this does is it allows you to understand, for example, the utilization and patterns of utilization of a medical product such as an obesity drug. And so what it does is it gives you the number of members and episodes of care in a particular period of time, or episodes of use in a particular window of time. You get information on the average number of dispensings, the average day supply, lengths of episode, gaps between episodes. There's an enormous amount of output actually with this tool. And two of the examples that are listed here, one again is the use of obesity drugs and patterns in use, as well as use of oral and intranasal steroids. And that's what I'm going to just show you a quick snapshot of. So if you can advance one, thank you. So if you went to the Sentinel website and searched for sinus stents, you would come to a page that has this information on it. And you can see here that there's a set of deliverables that you can click on, as well as related links, and then a description. So what this, in terms of the deliverables, what you're seeing here is the actual reports from the Sentinel analyses that were conducted using our tools and the output that was generated from that. So you're going to see that it's aggregated across all the different data partners that ran it. You'll see an overview tab in all of the reports that's kind of like a more detailed abstract or a summarized methods section that gives you a sense of the major parameters that were defined, when the data were run, which data partners, how many data partners ran it, et cetera. So I'm not going to walk through any single report. Really, there's simply too much output. But again, in the interest of giving you a sense of what's possible, this is an example where FDA was interested in the use of sinus stents with particular medical products, and then ultimately interest in potential diminished visual acuity. Before they answered that question, right, which if you go back to that schematic of the types of questions we can answer, that would be one where we're looking at a medical product and an outcome. First, and often this occurs where before we get into that question, which may ultimately be an inferential analysis, we'll start at the base and say, how many people use these particular products? What are their patterns of use? Get an understanding of these products in the database before we go forward with a more complex analysis. And so that's what I'm going to show you next. If you click on the next slide, what you're going to see is this is just a screenshot of one table from this type 5 analysis, again, medical product utilization. Not going to walk through all of the details here, but the point is that you get many different tables output from it. This is giving you descriptive statistics on the cumulative length of treatment episodes for 2 different kinds of steroids in the Sentinel distributed database. So you can see information on the cumulative episode length or treatment length in days for these 2 different types of products. So that's really all I'm going to say on healthcare, on the medical product utilization capability. And if you go click ahead, Liz, go back to this grounding slide. And what now we're going to look at is medical product switching tool. So this capability, which is perhaps in the more simplistic concept of just looking at medical products, is actually an incredibly flexible and complex analytic capability that we have. So this enables FDA and anyone who uses these tools on their own data to understand and identify switching patterns from one product to another. So for example, you might be interested in understanding the number of switches that occur from a brand to a generic, perhaps to another generic or back. There's all these different patterns that can be specified and that you can capture with this tool and then describe a lot of components of that switching and of the cohorts who have those switches. So again, this is essentially the elevator pitch of what each tool can do. And I'm just going to give you a little bit of a sense of what's possible. So this tool can give you an enormous amount of output. And what you're going to see is a little bit of an example where there was interested in understanding switching patterns for patient who received valsartan and ACE inhibitors and ARBs. And so if you go on the next slide, you can see here, this was among patients with heart failure. So again, this is the same orientation. If you go to the Sentinel website and you searched for valsartan or one of the other keywords here, you'd get the same kind of orientation where you can see the reports from the different analyses. And in this case, actually, where you see the related links, you can see that there was an ICP poster this year on this explicit question. And so if you go to the next slide, this is a screenshot of one of the tables. So you can see this is table 5A. This is showing you some of the statistics on the time to first switch among people who had the switching pattern that was of interest to FDA. So again, I'm not going to walk through all the details here, but you can see if you look at the second column in from the left that there was a particular switch pattern that was specified by FDA for this question. And what this table is showing you is information on the time from the first drug of interest to the second within this pattern, and you get all of this descriptive information on the time to that first switch within this broader pattern. So that is our type 6 or switching tool capability, again, at really the very highest level. So if you go to the next slide, and one more. So I'm not going to spend too much time talking about our pregnancy tool and its capabilities because Liz and Mayura are both going to speak about this in substantial detail. But I'll give you a big picture just to root you in it and to keep in the back of your mind as Liz takes over for the next session. So this is what we call our type 4 analysis. And this tool has the ability to identify women who have had evidence of a live birth delivery and then create pregnancy episodes. So as I said, Liz is going to talk about this in a lot more detail. But what then happens is within that pregnancy period, you can assess the utilization of different medical products overall by trimester, as well as in the period before pregnancy. And what it also does is this tool identifies a comparator group of women. So similar in terms of age and period of time and enrollment history and any inclusion or exclusion criteria, except they don't have evidence of a live birth pregnancy at that same period of time. And so you get this, you can understand utilization of particular products, both during pregnancy and not during pregnancy in the same broad type of women. And you get many different output in terms of the different metrics that are generated. You can see the number of pregnancies, the use by trimester, as well as a lot of other information. And like all of our tools, I should have mentioned this earlier, all of these cohorts can be specified in terms of inclusion and exclusion criteria, both in terms of enrollment period. So are you only including people who had medical and pharmacy for at least a year or 6 months? Are you restricting your cohort to people with asthma or some other condition, or excluding people who have a particular condition? And the example that I'm going to show you is actually an analysis that was conducted in support of an FDA advisory committee meeting that was on the product, it's also referred to as Makena, but hydroxyprogesterone and progesterone among pregnant women. So if you click on the next slide, what you see here is same kind of thing. So in terms of the landing page that you would see on the Sentinel website for this particular set of analyses. And what you see here is that there is a deliverable. So there is a Sentinel report that you can open up and review the actual results on. You can also see information and slides from the ICP 2020 presentation that was done, as well as information on the advisory committee itself. So what we did here with FDA was design an analysis to understand the utilization of particular products in the context of this question around Makena. And if you click on the next slide, you'll see one of the figures that was generated as part of this analysis. And so you can see here, this is the number of pregnancy episodes or pregnancies that had medical product use in the 2nd or 3rd trimester per 1,000 pregnancies. And there are each line is a different medical product that's being evaluated. So that's one of the analyses that was conducted as part of this broad set of analyses for FDA. And on the next slide, you'll see a brief reference to the advisory committee that was held in 2019, where these data were used. So if you go to the next slide, so again, you're going to hear a lot more about pregnancy for the remainder of the morning. And now I'm going to talk just briefly about our type 1 analyses, which are our background rates capabilities. So if you are interested in understanding how many people have hypertension in your data that is in the Sentinel Common Data Model, and you want to understand, calculate a rate of that condition, or if you want to calculate the rate of a particular event of interest, this is the tool that you would use. And the output that's included is the number of individuals who have the condition of interest, the denominator for that, as well as the rate itself. And so the example I'll show you is an analysis that was conducted to understand the presence of or evidence of hypertension in pediatric patients. So if you go to the next slide, you can see here that there was, this is actually the same thing. There's one report here for this. So if you were to click that line where it says deliverables, so you go to the next slide, this is an example of the output. So again, this was a type 1 analysis that was run by FDA to understand how many children in the Sentinel distributed database, in this case, it was 2008 through April of 2019, have evidence of hypertension. And the question was actually around which 2 different definitions that were used. So FDA had a couple of different ways of defining hypertension and wanted to explore those. So you can see here, the first definition was looking at 2 outpatient claims or 1 inpatient claim that had a diagnosis code of interest. And then definition 2 was more broad. And you can see here the number of members. So these would be the pediatric members who had a diagnosis. And then on the far right-hand side, you can see the rate of the members who had that diagnosis by the 2 different definitions. So again, just a big picture overview of what's captured by these tools. So if you go to the next slide. So I'm about to give you, again, I think crash course is probably the right phrase to use here for all this overview. And within the category of analytic tools that we have under you're interested in studying a medical product and outcomes associated with those medical products, there are many capabilities within this broad grouping that we refer to as type 2, which is essentially thinking about unadjusted rates of events among people with exposures of interest. I'd say one thing before I talk about this is to just mention something that I could have said earlier, is that all of these capabilities, we've organized them by the type of question that you might be wanting to ask or that FDA might ask. And if you have a question about outcomes only, you can use a type 1, et cetera. I think the really important thing to keep in mind, and that for those of you who are external to FDA, who are perhaps thinking about using these tools in your own data, you can always contact us with questions, is that one of the really great things about these tools is that sometimes you can use them for things that they weren't explicitly designed for, or you might make some modification and realize, when FDA comes to us with a question, they say, we want to study this question. What we'll often do is say, well, we can answer that question with this analytic tool, and this is the kind of output you would get, or we can actually answer it with this kind of tool and you'll get different output. And so sometimes it's really about thinking through, what do you really want? What are the most important metrics that you need and tables that you're looking for? So I wanted to mention that to keep in the back of your head, that while we've categorized these in a particular way to help explain what's possible, it is important to keep in mind that because there's so much flexibility, you can actually use tools for multiple things. So what I'll talk about briefly is the capabilities that we have for developing unadjusted rates of outcomes in the context of an exposure of interest. And there are, of course, many metrics that are output in many different tables that are generated by these sets of tools. But you would, for example, get the number of members who have a particular exposure of interest, the number who then have an event of interest, their days at risk, and rates calculated for those. And so what you'll see here is an example of mometasone nasal stent implants and the incidence of ocular events. So if you go to the next slide, again, this is showing you now that there were a number of reports that were run in this broad question that FDA had around the use of these different sinus implants and different outcomes related to visual acuity. And so if you click on the next slide, you can see here, again, this is just one bit essentially of one table that's generated by the tool. And you can see here the specific events of interest were glaucoma and cataracts, and they were being examined among people who had evidence of different specific stents. And so each row here in this table is a different product of interest. So it's individuals who have evidence of use of that product. And then we're examining here, you can see in that gray bar, glaucoma. And so you can see how many users there were for each product among a broader denominator of eligible members. How many were actually exposed to the product. So you're getting a rate of exposure. And then the far right-hand side, you're going to get the rate of the outcome among those who had evidence of use of that product. And you get counts of events and number of users with an event of interest. So again, really big picture overview of what's possible here. And again, these capabilities, if you'll remember, this was in the level 1 capability. So this is not adjusted. These are just descriptive analyses. All right, moving on to the next slide. This is, now we're going to talk briefly about inferential analyses in the context of type 2. So again, looking at exposures of interest and outcomes with inferential analyses. And this is all rooted in propensity score adjustment at this time. And there's really a very broad range of capabilities within our different propensity score analyses. And we can do fine stratification as well as inverse probability of treatment weighting, as well as propensity score matching. And so there's a lot here, and I'm only going to give you a very big picture overview, but the point is that you can generate propensity scores in your exposed and comparators of interest, assess outcomes of interest in those cohorts, and use propensity score for adjustment. And you'll receive also estimates of course, your point estimates of interest, hazard ratios, and confidence intervals. So if you go to the next slide, this is showing you an analysis that was conducted. This was a propensity score matching analysis among individuals who are 65 and over, comparing the use of 3 different oral anticoagulants, dabigatran, rivaroxaban, and apixaban, and outcomes of stroke and bleeding events. And if you go to the next slide, again, I'm not going to go into the details, but you can see here the point estimates and confidence intervals for the different comparisons for stroke and for, in this case, major extracranial bleeding. So again, this is about as fast as you can go through the propensity score adjustment capabilities within Sentinel. But what I would just say is, if you're interested, as I'll talk about in a moment, there's a lot of information on our website, on our public Git, where you can get documentation and more information about our analyses. So if you go to the next slide, this is the last capability that I'll mention. It's also the latest available. So this is our ability to do an interrupted time series analysis. And really, this was recently put on the Sentinel website. And what this does is it gives you the ability to understand trends in a particular endpoint of interest over time in the context of some point in time or multiple points in time. So for example, if there was a drug safety communication or a label change of some kind, and FDA wanted to understand the impact of that point in time change, they can use the interrupted time series analysis to do that. And the user acceptance testing use case, which you're going to hear about from Mayura for the pregnancy tool, what we did for this tool was examine the initiation of single ingredient LABA in the context of a drug safety communication that FDA had published. So moving on, the last couple minutes that I will use is to tell you about, if you go to the next slide, Liz. All right, so if you now want to either understand more about the tools because you're at FDA and you want to understand a little bit more about what you've been working with us on, or you're an external party and you want to actually use these tools yourself, if you go to dev.sentinelsystem.org, that's our public Git where you can find all of the SAS programs that I mentioned today. So if you go to the next slide, I'm going to very quickly go over this. So if you go to that website, you're going to get a list of all the big picture options or the broad categories of options. So one is our set of quality assurance packages. So again, if you had transformed your data into the Sentinel Common Data Model and you want to run the same checks we do, or you're just curious as to what the Sentinel checks include, this is what you would click on, and you would then be able to download the SAS programs, all the documentation, and all the information that you need to actually run such a program. So again, I think this has utility for everyone. I mean, quite frankly, many of us in the operations center go here to look at the documentation, but then also there's a lot more of the technical detail about what you actually need to use this, need to be able to use a tool, as well as the SAS programs themselves. So if you go to the next slide, so that's the quality assurance package. If you wanted to download one of the analytic tools that I mentioned today, let's say our pregnancy tool that Liz and Mayura are going to be talking about, you would click on that. And if you click ahead one level, you could also, so that is if you wanted to just look at the tool in its template form, where you could then specify the parameters, or you just want to review the documentation. What we also have on the Sentinel website is the analytic packages themselves. So for all of the inferential analyses that are conducted as part of Sentinel, we post, in the interest of transparency, those SAS programs themselves. So you'd be able to see, for example, the exact parameters that we specified that FDA chose, the code list, all the input files, et cetera. So for example, what you'll see listed here at the top row in small type, if you can read it, you'll actually see the analytic package that was run that generated the results that Mayura is going to talk about later this morning. So again, any inferential analysis that's run as part of Sentinel, the program itself is posted here. So you could really dig into understanding exactly what was done. So beyond just looking at the results, but really understanding a lot of the nitty-gritty details. So if you go to this next slide, this is just a screenshot of that. So if you had clicked on that top row, this is what you would see, and you'd be able to download within each of those folders a whole bunch of other files. So that's everything I wanted to say this morning about what is Sentinel, how is the network constructed, and a broad overview of our analytic capabilities. What's going to happen is for the next 2 sessions, Liz will speak, and then we'll take a 10-minute break, and then Mayura will speak. And what we'll do is, again, please, I know that there have been questions coming in through the chat, and I wanted to get through the talk, and I know that Judy's been responding to those. So please keep using that chat function. We'll hopefully have some time at the end. But what I'll do now is turn the presentation over to Liz, and the rest of the training is going to be focused on pregnancy-related work. And as Dr. Delpan said at the beginning of the session, it's such an important set of work that FDA conducts in the context of pregnancies. And the Sentinel system in particular is very well poised to be able to answer many questions in this context because of the size of the network, as well as now our analytic tools. So with that, thank you very much. And if there are any questions that came up that haven't been addressed yet in the chat during my talk, I'll respond to them. And in the meantime, I'll turn it over to Liz for the next session.
Thanks, Noelle. Excuse me just for one moment. It appears there is a box that is interfering with our view. I just want to make sure there's nothing I can do to fix the problem. It appears no. So if you're seeing a small box in the center of the slide that occasionally pops up, I apologize for that. I realize that can be distracting, but we'll just move on forward. So thanks to everyone for joining. So my name is Elizabeth Suarez, and I'm going to be talking through first how we create our linked mother-infant cohort. So as Noelle mentioned, there is a new table in the Sentinel Common Data Model, and this is called the Mother-Infant Linkage Data Table. And this table includes information on our eligible live birth deliveries, including the mother's ID and details on her delivery encounter. It includes information on eligible infants, and then of course it includes information on whether the mothers and infants were able to be successfully linked and able to be used for a linked analysis. So currently in the Sentinel distributed database, this table is populated by 4 of our data partners. So this includes 3 of our national claims insurers and 1 Medicaid data source. So we can use this table to identify live birth deliveries. We can also use it, of course, to identify our mother-infant pairs. It also has some information on certain infant characteristics, like information on their enrollment that we can use during our linked mother-infant analyses. And so when you're using this table with the Sentinel tool, the user can specify which of these mothers or linked mother-infants they want to include in their analysis. So the user can specify the linkage methods that they want to use. So this is something that we're going to talk through step by step as we go through this section. So this figure is going to give you a high-level overview for the steps that we take at the Operations Center with our data partners to create the MIL table. And so if you haven't picked up on it yet, I'm going to probably interchangeably use mother-infant linkage table and MIL table, and also probably interchangeably use mothers and deliveries. So if there's any confusion with that, please feel free to put a question in the chat box and we'll address it. But the first process in creating the MIL table is to identify our deliveries of infants that are eligible for the table. So first at the Operations Center, we create a package of analytic programs that identify the eligible mothers and infants. We send this to our data partners and they execute this against their data. And they send their results back to us at the Operations Center so that we can review them for accuracy. The next step is for our data partners to complete the linkage in their own data using their own source own process because they each have access to different data elements that may help them with the link. And then we move on to a quality assurance step where at the Operations Center, we distribute another analytic package to the data partners for them to run against their newly created mother-infant linkage table. They return the results back to us at the Operations Center so we can evaluate them and help them respond to any outstanding issues. And at this step, the data partners may have to return to the linkage process, and then we'd go back through the quality assurance steps. And we repeat this process until we have a final table that's been approved by the Operations Center and now can be used in our analyses. And if you're creating this table in your own data, of course, your process might look a little bit different. But as Noelle mentioned, we do have those quality assurance packages available for you on the website so that you can ensure that your newly created MIL table meets all checks to be able to be used for analyses. So as I noted, the first step in this process is identifying our eligible mothers and infants. So to identify the deliveries that are eligible for the table, we first identify female patients that have a ICD-9 or ICD-10 diagnosis or procedure code that indicates that a live birth has occurred. We limit the population to women who were between the ages of 10 and 54 years at the time of this live birth code. And we apply a 180-day washout period, which is a period prior to the live birth delivery code during which no other live birth code can be found in her record. We also have to ensure that she has 180 days of continuous medical coverage prior to the date of her live birth delivery code. And then for the table, we record some key information about the mothers, including her patient ID, her date of birth and age, the ID for the delivery encounter, the delivery encounter type, which is inpatient, outpatient, emergency, et cetera, the admission and discharge dates for this encounter, and then if it was a singleton or multiple delivery. And we determine that status using diagnosis codes that are found in the same encounter as the live birth delivery. Next, we need to identify the infants. So we identify all patients with a date of birth during the years of data available at each data partner. And then additionally require that this date of birth actually has to be at least 1 year after the start of available data. We also require that the infants have at least 1 day of medical coverage in their first year of life. And we record their patient ID, their birth date, sex, and the date of their first medical enrollment. So as I noted, the linkage process is different at each data partner and determined by each data partner because they have access to different information that might be useful to them for linking mothers and infants in their data. So most of our data partners use a deterministic method for the match, meaning they use an exact match between the mothers and infants on specific data points. So this might be something like a family subscriber ID. Some data partners also use probabilistic matching methods, meaning they use multiple pieces of information to make the best match possible. And so because there could be multiple gestation deliveries in our data, multiple infants could be linked to a single delivery, but of course only one linkage was allowed per infant. And so now that our match is complete, there's a new variable in the mother-infant linkage table that needs to be included. And so this variable indicates if a match occurred or not, and it also describes the method used for the match. And if there was no match made for a mother or infant, it gives a value for the reason why no match was made. And then we use these specific values to be able to select which deliveries and infants or linked pairs we want to include in our analyses later on. So now I'm just going to walk you through some statistics from the latest data that we have in the mother-infant linkage table in the Sentinel distributed database. So we currently have approximately 5.1 million linked deliveries available for analysis. And this was after a linkage rate of 78.7%. And so there's multiple reasons, of course, why this linkage wasn't perfect. The biggest reason probably being that mothers and infants aren't always insured under the same plan. So we may observe the mother or we may observe the infant within one data partner, but we don't have both to link. We also require that the mother had an amount of enrollment prior to her delivery. So she may not appear in the table despite being insured under the same plan as the infant, because she just didn't have enough time observed in the data for us to include her in the table. Data partners also only linked when they had confidence in the link. So of course you could increase your linkage rate by using less strict linkage criteria, but you're gonna have potentially some inaccurate linkages if you do so. So this table gives counts of deliveries included in the table currently and their linkage rates based on the birth type, which birth type here is indicating the number of gestations that was classified during the mother's live birth delivery hospitalization. So highlighted in the orange box here is our singleton deliveries. And overall, 95% of our linked deliveries were singletons. I've also highlighted this group because we currently only include singleton deliveries in our analyses, and we don't currently support an option to analyze the other gestation deliveries, but we include them in the table and we've completed the linkage process for them so that they're available to analyze if we increase our capabilities in the future. These tables also present the deliveries and linkage rates by maternal age and the encounter type of her delivery. So you see that the vast majority of the deliveries are happening to women between the ages of 20 and 44 years. So 97% of the deliveries were in that category. And 99% of all of our linked deliveries are occurring in an inpatient setting and were identified using inpatient records. And the linkage rates were 80% or higher in both of these groups. So this figure presents the deliveries and linkage rates by year. And you see some sharp jumps in as you go along by year, and this just indicates which when different data partners started contributing data, because not all data partners that contribute data to the distributed database contribute the same years. And the linkage rate does vary a little bit over time. That's the yellow line you see going along the top, which naturally is changing with the introduction of new data partners. And this linkage rate does change a little because each data partner has different data available to them to make their match. And also there's probably a different probability that they insure both the mother and the infant within their plans. You also see a little bit of a drop in the data for the later years. And this is mainly reflecting the data availability at each data partner and how frequently they update the data that they have formulated in the common data model. So now that we have our linked table, we do have to do a little bit more processing before we're able to actually use these deliveries for analysis. And so, as I noted, we currently include singleton deliveries in our analysis cohorts. And this is due to the additional complexity of analyzing multiple infants paired with a single mother. So when we look just at our singleton linked deliveries, we have 4.8 million currently available for analysis. We also need to consider whether or not they have drug coverage. So for inclusion in the table, to keep the table fairly general for whatever type of analysis we want to do, mothers and infants were only required to have medical coverage. But since we're primarily interested in looking at drug exposures, we need to also require that they have drug coverage. So once we add that requirement in, we have 3 million linked singleton deliveries where the mother and the infant both have medical and drug coverage. And then also, we need to specify a certain duration of the medical and drug coverage prior to the delivery, especially for the mother and also for the infant if we're looking at infant outcomes. And of course, how much duration you specify is going to have an impact on your sample size. So at minimum, we probably want to include duration, or we want to include medical and drug coverage for the duration of the pregnancy. And often we also want to make sure that we can observe a pre-pregnancy period. And so this is a period prior to the start of pregnancy when we might want to assess different covariates like pre-pregnancy medication utilization, any comorbidities, and healthcare utilization that the mother is accruing prior to the start of her pregnancy. So in this figure, you can see the two yellow bars correspond somewhat generally to those two criteria. And if we require 280 days of continuous medical and drug enrollment prior to delivery, we maintain about 83% of our original 3 million linked singleton deliveries that have both medical and drug coverage. And if we further require that we also observe at least a 90-day period prior to the start of pregnancy, and so we're requiring 391 days of continuous medical and drug coverage prior to the start of pregnancy, we maintain about 73% of our cohort. So if you require a longer duration prior to the start of pregnancy, of course, your cohort size is going to shrink. So you have to kind of balance the need for a longer period prior to pregnancy to assess the variables that you're interested in with the need to maintain a robust sample size for your analysis. So we recently completed an analysis that compared the characteristics of the deliveries in the MIL table currently in the Sentinel distributed database that were able to be linked to an infant and not able to be linked to an infant. So that's our linked and our not linked deliveries, limited to singletons here. And for that analysis, we required that the mothers had 391 days of medical and drug coverage prior to the delivery date so that we could cover her full pregnancy period and a 90-day pre-pregnancy period to be able to observe different comorbidities that are happening in this pre-pregnancy period. For this particular analysis, we didn't add any additional enrollment criteria for the infant. So we just required that there was an infant that could be linked to the mother. And we ended up with about 2.2 million linked singleton deliveries and 470,000 not linked deliveries. And you can see that the number of pregnant women is smaller here because one woman could contribute multiple deliveries to the analysis. She could have multiple deliveries in the MIL table. So we see here that the linked deliveries are on average a little bit older than our not linked deliveries. So the linked deliveries were about 31.1 years on average at the time of the delivery. And the deliveries that were not able to be linked to an infant were on average 27.7 years at the time of delivery. And in the age distribution to the right, we see this really reflected in the younger age categories. The not linked are the yellow bars and the linked are the blue bars. And we see that about 43% of our singleton live birth deliveries that were not able to be linked to an infant are age 24 years or younger at the time of delivery. And so we also see a bit of a difference in the proportion of deliveries that were able to be classified as preterm. And among our linked deliveries, about 5.7% were preterm. It's slightly higher in our not linked deliveries at 7.3% classified as preterm. So we also, I'll just present some data on race, ethnicity, and healthcare utilization for these two cohorts. You can see in the table on the left that unfortunately one of the biggest takeaways here is that race and Hispanic status are actually unknown for a lot of women in this group, and that's primarily because not all of our data partners are able to contribute this data. but we do see that there is a bit of a difference in women who are classified as white. So this is slightly higher in our not linked deliveries compared to our linked deliveries. We also see that women with a linked delivery are more likely to be classified as not Hispanic than our non-linked deliveries. The table on the right also gives some metrics on healthcare utilization, and this was assessed just in the 90 days prior to pregnancy start, so just that pre-pregnancy period. And a lot of these numbers are pretty small because it's a pretty short period of time, but we do see that our not linked deliveries have a slightly higher mean number of ambulatory or outpatient encounters. And so the last thing that we looked at for this group was various pre-existing conditions among the linked and not linked deliveries. And so these two figures on this slide are just giving you a snapshot of some of the conditions that we looked at. And again, the not linked deliveries are the yellow bars and the linked deliveries are the blue bars. And we see here that our not linked deliveries are more likely to have a diagnosis of depression, anxiety. They're more likely to have codes for drug abuse, tobacco use, and alcohol abuse, and also obesity than our linked deliveries. Where on the left-hand side, we see that the linked deliveries were more likely to be diagnosed with acquired hypothyroidism. So some of these differences, of course, can be contributed to age. As I showed you previously, our not linked cohort is a bit younger than our linked cohort. Okay, so now that I've given you an overview of how the linkage table is created and how it's characterized and how our data currently looks in the Sentinel distributed database, we're going to now talk through how do you actually parameterize a descriptive analysis that you might want to do on a pregnant cohort using the Sentinel analysis tools. So this figure is going to act as a key for the remaining sections of today's training. So we're going to focus on how to create a cohort of deliveries from your analysis, how to do a descriptive analysis, and then how to do an inferential analysis. And so I'm going to start in this section with steps 1 through 4. And then after we take a brief break, Mayura is going to pick up steps 5 through 7 and also walk us through an actual analysis that we did looking at topiramate use in pregnancy and the risk of oral clefts in infants. So we're going to start with walking through how do we identify our cohort of interest. And this could, but doesn't necessarily have to, include use of the mother-infant linkage table. And so we start with all female patients. And then we have the option to select if we want to include all live birth deliveries linked to an infant, or even live birth deliveries not linked to an infant, if that happens to be the population that you're interested in looking at. And we use this cohort to describe medical product use and other cohort characteristics. And so as I noted briefly before, there are a couple of methods for identifying our deliveries for analysis. And we don't necessarily have to use the MIL table. It's not always necessary to look at pregnancies in general. So the first method we can use is just to identify live birth deliveries in the data using ICD-9 and ICD-10 codes. So this doesn't require use of the mother-infant linkage table. And so if you're just interested in data on the mother, so you're just interested in analyzing something that happens prior to or during pregnancy or even after pregnancy, if it's limited to the mothers, you can use this method. And an example of this is if you want to just characterize medication utilization prior to and during pregnancy, if you want to characterize comorbidities among the pregnant women, or if you want to conduct even an inferential analysis, but you're only looking at a maternal outcome and you're not concerned about the infant outcomes. And so this is advantageous because it doesn't require that you have the mother-infant linkage table in the common data model. And so for your purposes, you can do an analysis on pregnancy currently without having to create that linked table. And for us, when we're analyzing in the Sentinel distributed database, this could be really advantageous for us because, as I noted, currently the mother-infant linkage table is only populated by 4 of our data partners. And so if we're not interested in infant data, we can greatly increase our sample size by not using that table and just selecting deliveries using ICD-9 and ICD-10 codes. On the other hand, if you do need infant data, or if you need knowledge of the linkage status, you're going to have to use the mother-infant linkage table to select your cohort. And so obviously, if you want to look at an infant outcome to do an inferential analysis between a maternal exposure and an infant outcome, you'll have to select your cohort from the linked deliveries. It might also be relevant if you want to look at medication utilization or other comorbidities among deliveries that are linked to infants, if you want to know that linkage status. And that might be true if you're doing an analysis in preparation for an inferential analysis using the infant data, if you want to characterize the mother's medication use in preparation for looking at it in relation to an infant outcome later on. Also, you may want to look at your linked deliveries because linked deliveries may have less misclassification of the delivery status than the deliveries overall, because we do know they were in fact able to be linked to a live birth infant. So that being said, I'm just going to quickly walk through how we actually do these 2 different methods. And so first, if we're using ICD-9 and ICD-10 codes, this is similar to what I just described for how we actually create or identify the deliveries that are going to be included in the mother-infant linkage table. But now we're doing this process within creating our cohort for analysis later. So the user specifies a list of ICD-9 and ICD-10, whichever is relevant for your analysis, diagnosis and procedure codes that indicate a live birth delivery. And the user can also specify the encounter type for this live birth delivery. So if you want to only limit to inpatient encounter types, you can do so. And in this example, the live birth delivery date will be set to equal the admission date for the delivery encounter, where the live birth delivery code was found for each woman. And then using that date, the user can also define a washout period, during which no other live birth delivery codes can be found in her record. So if we're selecting instead from the mother-infant linkage table, we specify which match method we want to use. And so this is going to select the already defined deliveries from the MIL table. And I've listed here the 5 match method codes that we currently use to indicate the match has occurred across one of our data partners. This might look different in your own data, but you're able to select all of the match methods if you want all of the linkages, or if you just want a specific match method, you can do that also. You have flexibility in defining which match methods to select from the MIL table to get your linked mothers and infants. And so there's a few other parameters that the user has to define to pull linked mothers and infants from the table. One of them is the maximum number of days between the mother's delivery admission date and the infant's birth date. So because the admission date may not actually be the date that she gave birth, there could be a gap between these 2 dates. Additionally, the user specifies a maximum number of days between the infant's birth date and the infant's first enrollment date. And infants aren't necessarily enrolled in their insurance plans on their date of birth. The parents actually have generally a 30 to 60 day window to actually enroll the infant. So this enrollment date may happen at some point after the start of birth. So if you want to limit the gap between the date of birth and the start of enrollment, you have the ability to specify a maximum number of days. And then when we actually complete analyses using these linked mothers and infants, the delivery date is no longer used as just the live birth delivery code date. We actually update this to match the infant's birth date because, of course, that's likely going to be a more accurate representation of when the date of birth actually happened. So now that we have our live birth deliveries either identified from codes or identified from the mother-infant linkage table, the user can again define the washout period during which no deliveries can occur prior to the live birth delivery date. And now we have to also require our continuous enrollment requirement. For the mother, we can look at her enrollment prior to the delivery date and set a number of days. So this is where you might say I need 391 days prior to the start, or prior to the delivery date, to ensure that I'm observing her full pregnancy period and also perhaps a 90-day pre-pregnancy period. And then you can also require enrollment after the delivery date. And so this would be important for the infant. If you are looking at an infant outcome, you probably want to ensure that the infant is enrolled for the entirety of that outcome window. And when we require enrollment after the delivery for a linked mother-infant pair, it requires enrollment for both the mother and the infant together. So now we have decided on our cohort of deliveries, either defined using codes or pulled from our mother-infant linkage table. And we've applied some washout criteria and we've applied some enrollment criteria. And now we need to actually estimate the duration of the pregnancy. And we need to estimate the start date of the pregnancy. And we do so using an algorithm that estimates gestational age. So in claims data, as you might be aware, last menstrual period is not recorded. So it needs to be estimated. And the Sentinel tools do so using an algorithm that was published by Lee et al. This is actually a screenshot of the top of the validation paper for this algorithm. And this original algorithm includes ICD-9 codes that indicate gestational age to assign the gestational age for each delivery. And they validated it by comparing to linked birth certificates as the gold standard. So we have since taken this algorithm and expanded it to include ICD-10 codes as well. And the performance of the algorithm is good. It does underestimate the prevalence of preterm birth, but it has high sensitivity and high specificity for identifying trimester-specific medication exposures. So this is compared to when the trimester dating was defined from birth certificates instead of from our algorithm. So we do quite well in just assigning whether or not a woman was exposed to a particular medication in a particular trimester. And so now I'll walk through step by step how the algorithm actually works. And so the first step here is to have a list of ICD-9 and ICD-10 codes that indicate gestational duration. And the user can define a window surrounding the delivery date when these codes should be identified. So we typically use a window of 7 days before and after the delivery date to collect all of the duration codes that appear in the mother's record that should be considered by the algorithm for assigning the final gestational age. And so if multiple conflicting gestational age codes are found in the record, the algorithm uses a priority ranking to determine what the final gestational age should be assigned as. And so the highest priority code here are these gestational week specific codes. So these are codes that actually do give a duration in the description of the code. So for example, here I have an ICD-10 code. This is D3A.35, and the description is 35 weeks of gestation. So we actually know approximate duration that we can apply if this code appears, and so we have an average duration in weeks and days that we would apply in the presence of this code. And so if there are no gestational week specific codes that appear in the record in the window that we've defined, the next highest priority code are codes that indicate preterm status but are vague, meaning they don't specify an actual gestational age in the description that we can use. And so, for example, this ICD-9 code of 644.21 indicates that there was an onset of delivery before this 37 completed weeks of gestation. And the duration in weeks and days, we assign an average duration to this code, and other codes that are similarly vague have other durations assigned to them based on what was decided to be most accurate for the algorithm. And then if there are no gestational week specific codes and there are no vague preterm codes, we next prioritize codes that indicate a post-term status, but also do not specify a specific gestational age in the description. So this ICD-10 code 0480.0 is a code for post-term pregnancy, and we assign it an average duration in days and weeks of 41 weeks and 287 days. And then finally, there's going to be a lot of women who don't have any of these codes assigned to their record. And so in that case, the user specifies what the default gestational age is. And we typically use a value of 273 days, which is a duration for a term delivery. So now that we've selected our duration, we count back from the delivery date by our given duration. And we then can classify what we call the start of pregnancy date. And then once we have a start of pregnancy date for everyone, we can actually date when the trimesters start, and we can use those dates to classify our medication exposures, our covariate windows, et cetera. We can now actually do our analysis on this cohort of deliveries. So now we're moving into how do we actually do a descriptive analysis. And one option that you might be interested in is to compare medication utilization among pregnant women to a group of reproductive age but not pregnant women in the database. And so this would be to compare utilization of medications between women who are pregnant and women who are not but are otherwise fairly similar. So to do this, we can opt to create a non-pregnant comparator cohort. And this is done pretty simply. We've already selected our female patients, and we've selected which pregnancies we want to include. So either all of our pregnancies or those linked to an infant, et cetera. And now we're going to select non-pregnant matched time periods. And these are periods during which there's no evidence that a live birth delivery has occurred, but they're otherwise matched to our pregnant patients on age, date, and site. So we do this by first, the first line in blue here represents an actual delivery in a woman. So we have a real delivery date. We have estimated her entire pregnancy duration and her start of pregnancy as illustrated by the blue bar. And so now we're going to match on age, site, and date to a woman that doesn't have a live birth delivery code on that same date. And we're going to require that she has no live birth delivery code for the entire matched duration of that pregnancy episode. She also has to meet all other enrollment and other eligibility criteria that we've set to be included in the cohort. So So the next step in our descriptive analysis is to actually identify the medical products that we want to analyze. So first I'm going to walk you through what metrics are available to us. And so we have our delivery date, we have our full pregnancy period, and we have our estimated start date of pregnancy of second trimester and of third trimester. And the user also has the option to specify this pre-pregnancy period, and the length can be whatever you decide it should be. And this is a period which will also look at whatever medical products we defined. We'll also look at the utilization during that period. And so these are some default statistics that are output. And so we get the number and proportion of women who, or of deliveries that have use of the medical product in the user-defined pre-pregnancy period. We also get counts of women who have any use in each of the 3 trimesters, and then a count of any use at any time during the pregnancy period. We also get metrics on whether or not there were women who had use only in the first trimester, only in the second, or only in the third. And then if they had evidence of use in each of the 3 trimesters, we also get metrics on that. And so additionally, automatically, we get output on the number of episodes within each of these periods. And so in order to define when medication exposure is happening during pregnancy, we have to first define what we're calling an exposure episode. And so this is a period of medical product use that we create using the raw data of the dispensing date and the day supply and potentially some other user-specified options about gaps in use or extensions in use that you think are relevant to apply given whatever drug you're interested in characterizing. And so the Sentinel tools do allow for a lot of flexibility in how these exposure episodes are created. And so I'm just going to walk through a couple of kind of major example of processing that you can do for creating these medication exposure episodes before we actually try to date their exposure during pregnancy. And you can always refer to the documentation online, as Noelle pointed out in the previous section, and learn more about the options for creating exposure episodes when you're using the tools. But first to start, I'm going to walk through this process that we call stockpiling. And so this process occurs when refills happen prior to the end of the day's supply for the previous fill of the drug. So you can see the dark blue bars in this figure represent 3 different dispensings of the same drug. And the dispensing date of the second and the third dispensings are happening before we get to the end of the 30 days of the first dispensing. And this isn't an unexpected pattern to see in the data because patients typically don't wait until it's the day when they need a new refill to go to the pharmacy and refill their drug. So it's not unexpected to see that they're actually refilling the drug prior to the end of the previous fill. But if we were to take these dates at face value, we would have a continuous active treatment period of 83 days. And that might not accurately reflect the number of days that this patient was actually exposed to this drug. So the process of stockpiling adjusts the dispensing dates. So if there is overlap, the second date is pushed to the end of the day's supply of the first date. And this creates now a potentially more accurate exposure period of 90 days of continuous active treatment. Alternatively, a patient might also have dispensings and day supplies that do not overlap, but they're close enough together to suggest some sort of continuous treatment happening. So the user has the option to specify gaps that are allowable between the end of the day supply and the next dispensing date. And also, if it's relevant, to add an extension where we would still consider this patient exposed to the drug after the end of their last day supply. And so using these assumptions, we instead create a 128-day episode of continuous treatment instead of just the 3 non-overlapping 30-day supplies. So now we need to actually date these treatment episodes in pregnancy. So we need to determine the overlap with the different pregnancy periods. And so in this example patient, they have this 128-day treatment episode that we just created using our assumptions about gaps and extensions. And here is that patient's pregnancy and the same aligned on dates. And so if we are defining her medication exposure based on whether or not a treatment episode overlaps with a certain period of pregnancy, we would say that this woman was exposed to this particular drug in the pre-pregnancy period, in the first trimester, and also in the second trimester, because you can see that that blue bar is overlapping with each of those periods of her pregnancy. Alternatively, we might actually want to define exposure based on whether or not the dispensing happened in each of the periods of pregnancy, as opposed to having a day supply or a treatment episode overlap. And this might just be because you have a little bit more certainty that the medication was actually taken if you see the dispensing happening within your period of interest. And so this often is a sensitivity analysis that might be done in a pregnancy analysis just to understand whether or not there's any potential misclassification in her exposure status. And so in this case, I broke down this 128-day treatment episode back into its original components of the 3 30-day dispensings. And if we overlay those 30-day dispensings over her pregnancy timeline, and now we just want to look at the dispensing dates, we see that she's classified as being exposed in the pre-pregnancy period and exposed in the first trimester, but not exposed in the second trimester because one of these dates does not occur in the second trimester. And so now I'm just going to walk you through the results of 2 examples where we actually characterize medication exposure during pregnancy. So in the first example, we sought to characterize use of a wide variety of medication classes in the linked deliveries in the MIL table and the Sentinel distributed database. And for this example, we used the definition of an overlapping medication episode to define gestational timing. In the second example, I'm going to just show you some metrics on the utilization of topiramate and lamotrigine use in pregnancy. And we compared their utilization during pregnancy to utilization in a matched non-pregnant comparator cohort. And we did this to inform our planned inferential analyses that Mayura is going to talk through after the break, where we're interested in looking at the risk of oral clefts in the infants. So this figure shows 15 broad groupings of drugs, and I'm going to walk through a couple of individual examples, but the first data point here that we have on the left of this figure is whether or not there was any use in the 90 days before pregnancy start. Then we have any use in the first trimester, any use in the second trimester, and any use in the third trimester. And so the most common category that we found were anti-infective agents. So this is not too surprising because it includes drugs like antibiotics that are given quite frequently to women during pregnancy. And we found that about 50% of women in our linked cohort had use of an anti-infective drug at some point during pregnancy. The next interesting trend here is gastrointestinal agents. And you see in the pre-pregnancy period, only about 6% of women had any use of these drugs, and it jumps up pretty high to about 19% in the first trimester. And so this category includes our antiemetic agents, which are commonly used to treat nausea and vomiting in pregnancy. So this big increase in use in pregnancy is not unexpected. And about 26% of our linked deliveries had any use of one of these drugs at any point during the pregnancy period. Next, we'll look just quickly at contraceptives. And so we see, not unexpectedly, that there is some use in the pre-pregnancy period that then does drop off appropriately in the first, second, and third trimesters. And then next most common was endocrine therapies, which includes corticosteroids, antidiabetics, estrogens, et cetera. And about 19% of women had any use of these during pregnancy. Next is respiratory therapy agents, which includes a wide variety of drugs like antihistamines, some nasal sprays, asthma drugs, et cetera. And about 20%, again, of women had any use of these at some point during her pregnancy period. And then central nervous system agents are also commonly used and also a commonly studied group of drugs. This includes our antidepressants, our anticonvulsants, benzodiazepines, and other drugs. And about 14% of the linked deliveries had use of these drugs at some point during their pregnancy. And then pain medications were also somewhat common. This includes both NSAIDs and opioids. About 14% of women had use of these at some point during pregnancy. And then I won't highlight any of the other remaining categories, but about 5% of women or less had use of these drugs in each of the pregnancy periods. And the full results of this analysis with even more breakdown of each of these categories will be available on our website soon. So you'll be able to kind of dig into the results on your own a little bit more in the near future. The second example I'll walk through quickly is utilization of topiramate and lamotrigine. And these are anticonvulsant and mood stabilizer drugs that have been of interest in a lot of previous safety analyses outside of Sentinel. And so we decided to look at utilization in Sentinel to understand if we can see similar results in our data. And we used just linked mothers and infants from the mother-infant linkage table and ended up with about 1.5 million linked deliveries and the exact same number of non-pregnant deliveries, non-pregnant episodes to compare to. So these are women who are not pregnant, so we can compare utilization between pregnancy and a not pregnant period. And so these figures show topiramate use. The live birth cohort is the dark blue line, and the non-pregnant cohort is the light blue line on the figure to the left. And you see there is a really big differential in the amount of use. So there's a lot less use happening of topiramate among the pregnant women than the non-pregnant women. In the bar chart to the right, the first statistic is any use in pregnancy, and the second statistic is use in every trimester, which is somewhat suggestive of some continuous use. And we see that a very small proportion of women in our cohort, of our pregnant women, had use of topiramate possibly throughout her pregnancy, so 0.3 per 1,000 women. And even among our non-pregnant cohort, we see evidence that women are not really using this drug continuously because there is somewhat of a large differential between women who had any use at 8.9 per 1,000 compared to use in each of the trimesters at 4.8 per 1,000. And this figure just shows the same exact statistics, but now we're looking at lamotrigine. There's still a differential between live births, between our pregnant cohort and our non-pregnant cohort. It's not quite as large as we saw for topiramate. And we do see on the right that while 12.8 per 1,000 of our non-pregnant women used this at some point during their matched pregnancy period, there still weren't that many continuous users. So this is 4.9 per 1,000 continuous users among our non-pregnant cohort, which was similar to what we saw for topiramate. And so finally, this is just showing those same numbers for topiramate and lamotrigine, and this is just looking at our pregnant women. And so this is just directly comparing utilization of these two drugs in pregnancy. And so we see that lamotrigine is more common, but both drugs do drop from the first to second trimester. And the higher utilization of lamotrigine by pregnant women compared to topiramate isn't unexpected. This is what we see elsewhere published about these drugs, because topiramate has been associated with certain birth defects in previous publications. And so this is the analysis that Mayura is going to pick up in the next section of our training after our short break. So that concludes this section of our training. I'm not sure, I'll pass it over back to Noelle to determine if we want to take some questions now, or do we want to wait until after the break and after Mayura has completed her section.
Yeah, thanks, Liz. This is Noelle. Yeah, I think in the interest of time, we'll break now. And if everyone can keep putting their questions in the chat, I know Judy has been on top of it. So we'll take a 5-minute break until 11:05. And if you could just go on the next slide, Liz. And then when we come back in a few minutes, Mayura will pick up for the last session. Hopefully we'll have a little time at the end for final questions, but please do keep using the chat, and we'll see you in a few minutes. So 11:05, please. All right, welcome back, everyone. We'll just wait another moment before Mayura starts at officially 11:05. So Mayura will be giving the last talk of this public training. Hopefully we'll have a few minutes at the end, but if not, again, as we've been saying, please keep putting your questions in the chat. Judy's been taking care of those as the rest of us are doing the training. And we'll also have a post-training survey at the end. So please do stay around to complete that. And as we said, all the slides will be posted on the Sentinel website. So you will have those for reference later. So without further ado, Dr. Mayura Shinde will be giving the last presentation of the morning. And Mayura is an investigator and epidemiologist in the Sentinel Operations Center.
Thank you, Noelle, and welcome everyone to the last session of our training today. I'm Mayura Shinde, as Noelle mentioned. I'm an investigator at the Sentinel Operations Center, and I'll be walking you all through to the inferential analysis capabilities that we have available with our pregnancy tool. Okay, I was just having a lag in controlling. So I'm going to build on what we discussed this morning about the routine querying tools that Noelle described, as well as how, some of the descriptive pregnancy analysis capabilities that Liz covered. And I'll be taking it to the next step and discuss how we can use our tools to evaluate maternal and fetal outcomes associated with perinatal exposures during pregnancy. And these we refer to as inferential and analytical capabilities for the pregnancy. And before we discuss the inferential analysis capabilities, we would like to introduce a use case study that examined topiramate use in early pregnancy and risk of oroclep. And we use this use case study as an example to test the capabilities of our tool. So for our use case, we selected the paper published by Hernandez and colleagues that estimated the risk of oroclep with topiramate use during early pregnancy. They used the US Medicaid analytical extract database from 2000 to 2010 and identified around 1.3 million live birth pregnancies. And they found that the maternal use of topiramate during the first pregnancy was associated with a threefold increased risk of oroclep after controlling for confounding. We selected this study given our pregnancy tool also identifies pregnancies that are ending in a live birth delivery, and now we are able to assess infant outcomes like oroclep as this described with the mother-infant linkage data that we have available. Topiramate has been approved for epilepsy and migraine, and it may be used off-label for bipolar disorder, chronic disease weight management, as well as alcohol dependence. The drug was previously classified as Category D, which means that there was positive evidence of fetal risk based on human data, but the potential benefits from use of the drug among pregnant women may be acceptable in certain situations despite risk. FDA had also released a safety communication in 2011 that there's an increased risk for the development of cleft lip and or cleft palate in infants who are born to women who are treated with topiramate during pregnancy. Cleft lip or cleft palate is the second most common birth defect in the United States, and it affects 1 in 1,600 infants who are born with cleft lip with cleft palate, and 1 in 1,700 infants who are born with cleft palate. And several risk factors can increase the likelihood of cleft lip and palate, including family history, smoking, diabetes, as well as exposure to certain environmental substances like alcohol, prescription drugs such as anti-epileptics. So the objective of our use case study was to assess the risk of oroclep with topiramate use during the first trimester using the mother-infant linkage data that we have available within the Sentinel distributed data. We included data from January 1st, 2000 until end of September 2015, and we included women who were between the ages of 12 to 55 years and who had no evidence of chromosomal abnormalities and teratogen medication use during pregnancy. And we conducted two sets of analysis that were outlined in the Hernandez paper. First, a primary analysis that compared the risk of oral cleft among pregnancies that had topiramate use during first trimester to an unexposed cohort, including no exposure to topiramate or other anticonvulsants during the first trimester or the pre-pregnancy period. We also conducted an active comparator analysis that compared the risk of oral cleft between topiramate and lamotrigine use during the first trimester. So this was a very quick overview of the use case study that we use for testing of our tools, and I will be sharing results from our testing shortly. But let's walk through the steps that are required when we are conducting an inferential analysis using a pregnancy tool. And these include first creating the exposed and the reference cohort, identifying the maternal or the infant outcome, thus evaluating the relation between the exposure and the outcome. And throughout the section, I will be giving general descriptions of the tools and the parameter options that we have available of the tools. And then I'll describe what specific choices that we made with our tools for the topiramate use case study. So let's move on to the first step of our inferential analysis, that is identifying our exposed and reference cohort. And this is a schematic that Liz described, in her training, how we can define our cohorts when conducting a pregnancy analysis. So we'll first start with all eligible females in the database and identify the live birth pregnancies as well as a non-pregnant cohort that includes women who did not have an observed live birth pregnancy and that are matched to the pregnancy. And we could use these cohorts in order to conduct descriptive analysis, describe the cohorts, as well as assess medical product use during the pre-pregnancy period, as well as during pregnancy. We could stop at this step, or we could take one step further and compare the maternal and fetal outcomes among pregnancies that are exposed to a medical product of interest. So from our live birth pregnancy, we can define pregnancies that are exposed to a medical product of interest and also define a reference cohort, which could include either unexposed pregnancies or pregnancies that have been exposed to an active comparator drug of interest. We can then describe the cohort characteristics for both the exposed as well as the reference cohorts, and then compare the risk of maternal and fetal outcomes between these cohorts after controlling for confounding. So let's get into the details of how we can define our exposed and reference cohorts. So when we think of exposure in claims data, we often think of exposure during a specific period of time. And within pregnancy analysis that we conduct using claims data, our exposure is usually binary because the biological relevant window has already been defined. So we can classify as pregnancies that are either exposed or unexposed or exposed to the comparator drug during a relevant time window. And using a tool, we can define a specific exposure window. That is, we can define exposure during a trimester or even a gestational week. But please do know that we're working with claims data and that we used an algorithm in order to estimate the pregnancy start. So gestational week may be slightly more misclassified than trimester. And earlier in her presentation, Liz also covered how we can create exposure episodes by combining the dispensings as well as the day supply together to create a treatment episode. And when we are conducting inferential analysis, we will still create the treatment episode and overlay them on the pregnancy period so that, we can assess whether, that given pregnancy had an exposure during the defined exposure window. So what I've shown here on the screen are two pregnancies with delivery date on the right and the estimated pregnancy start on the left, along with trimester periods which are designated by the vertical bar. And for this analysis, let's say we consider, the exposure relevant window as the first trimester. So we can see that for the first pregnancy, exposure A was observed during the first trimester, so this pregnancy will be classified as being exposed. For the second pregnancy, what we observe is that it does not have the exposure during a defined exposure window. So it will be classified as being unexposed, although it does have the exposure A during the second trimester. But since we had defined our exposure window being the first trimester, so this pregnancy will still be classified as being unexposed because it didn't have the exposure during a defined exposure window. So if we want to conduct our analysis using an active comparator drug as our reference cohort, then we would require that the pregnancy has evidence of the comparator drug use during our exposure window. So you can see that the first pregnancy is still a exposed cohort where we require that the exposure A was required during the first trimester, but now you can see that in the second pregnancy it has exposure to the comparator drug during the first trimester. So this will be classified as, again, the reference cohort since it had the exposure to the comparator drug during a defined exposure window. And further, let's say consider a situation as is shown in the second pregnancy, where it has exposure both to our exposure drug as well as to a comparator drug, which is shown by the blue bar. So it will be really hard to determine, which cohort this pregnancy should be assigned to. So this pregnancy will essentially be excluded from our analysis. So for our topiramate replication study, as I had mentioned earlier, we conducted two sets of analysis. We had a primary analysis that used an unexposed reference cohort. And for the unexposed comparator analysis, we defined exposure as pregnancies that had a dispensing of topiramate during the first trimester. So you can see that the first pregnancy did have a dispensing for topiramate during the first trimester, and this will be the pregnancy will be classified as being exposed. For our unexposed cohort, we defined pregnancies that had no dispensing of topiramate in the first trimester or even during the pre-pregnancy period. So we can see that the second pregnancy satisfied that criteria, and so it will be classified as being unexposed. Then moving on to the second analysis that we conducted that used an active comparator as our reference cohort, we used the same definition for a topiramate exposed cohort, which required dispensing of topiramate during the first trimester, and we also required an additional criteria that no lamotrigine dispensing was observed during the first trimester or the pre-pregnancy period, so which you can see by the purple bar. So it did not have a lamotrigine dispensing during that time period, so this pregnancy will be classified as being exposed. For our lamotrigine comparator cohort, we required that the pregnancy had a dispensing of lamotrigine during the first trimester, and also required that they did not have a dispensing for topiramate during the first trimester or the pre-pregnancy period. So you can see that in the second pregnancy, so this pregnancy will be classified as a reference cohort, given a definition that we specify for active comparator. So now that we have defined our exposed and reference cohorts, we can further refine our cohort. And what I mean by that is, we can apply additional exclusion or inclusion criteria that we would want to specify for our cohorts, as well as define a covariance. And for refining the cohorts, we have three options for anchoring our evaluation windows. So the first one is the pregnancy start. The second anchoring option that we have is the medication exposure date. And the third anchoring option that we have is the delivery date. And we can, then, apply our inclusion or exclusion criteria around any of these anchoring dates. And as with all parameters for our tools, the choice of the anchoring date as well as the evaluation window is project specific. So let's look at, what we did in our topiramate study. So for our topiramate study, we used the pregnancy start as an anchoring date, and we have specified 2 exclusion criteria. The first one was that we required that pregnancy had no diagnosis codes for chromosomal abnormalities starting from the pregnancy start date until 273 days after the pregnancy start. And we used 273 days that corresponded to 39 gestational weeks. And this evaluation window basically allowed us to capture the entire pregnancy period for majority of the pregnancies that were included in analysis. We also required that pregnancy had no dispensing of a known teratogen during the first trimester, as pregnancies that are exposed to teratogens may have increased risk of oral eclipse. So that's why we didn't want to include them in our cohort. For the covariates, we have the same 3 options for anchoring date. That's the pregnancy start, the medication exposure start date, or the delivery date. But specific to the topiramate study, we used, again, our pregnancy start as an anchoring date. And we assessed different covariates. So we evaluated comorbidities in the 90 days around the pregnancy start. We also assessed medication use during the first trimester after the pregnancy start, as well as we also assess some healthcare utilization metrics in the 90 days prior to the pregnancy start. And with our pregnancy tools, we have different healthcare utilization metrics that we have available, including number of inpatient stays, ED visits, outpatient visits, number of generic medications that are dispensed, and so on. So now that we have looked at, how we can define our exposed and reference cohorts, the next step in our inferential analysis is to, identify our outcomes of interest. So this is the second step that we have, where we would identify the maternal or the infant outcomes that we would like to express. And outcomes are usually assessed after an exposure, but in pregnancy analysis, defining the etiological relevant window can be a bit tricky. And in order to accommodate this complexity, we have the same 3 anchor dates that I had mentioned earlier, but our tools also allow the flexibility to use different anchor dates for the start of the evaluation window as well as the end of the evaluation window. So let's take an example of, for infant outcomes. And usually for infant outcomes, we would like to, assess for the infant outcomes after birth. So we would anchor on the delivery date. And then we would want to assess a specific period after the delivery date. So basically, then we would specify the start of our evaluation window using delivery date as an anchor date. So our evaluation window would start from the delivery date until a specific period after the delivery. And then when we are assessing maternal outcomes, things can get slightly more complicated because we may want to assess the maternal outcomes during pregnancy as well as a specific period after delivery. So we may want to use different anchoring dates. So we are, kind of covering the entire pregnancy as well as certain time periods after delivery. So let's take an example for gestational hypertensive disorders. And we may want to assess the gestational hypertensive disorder starting from the 20th week of the pregnancy until 90 days after delivery. So we would like to, use the pregnancy start for the start of our evaluation window. and specify to evaluate a certain number of days after the pregnancy starts. So let's say 140 days after the pregnancy starts, which would correspond to the 20th week of gestation, and then use the delivery date as an anchoring date for the end of the evaluation window, so that we are able to evaluate up to 90 days after delivery. So essentially, using these two separate anchor dates for assessing of this maternal outcome will help us to assess this outcome starting from the 20th week of gestation until 90 days after delivery. So for the Cohort study, I would like to, kind of walk you all through how we defined our infant outcome of oral cleft. So in order to define oral cleft, we used an algorithm definition that required 2 or more diagnosis codes for oral cleft and 1 diagnosis code or 1 procedure or surgical code for the oral cleft. We did use delivery date as an anchoring date, and we started our evaluation window for the outcome assessment starting from delivery date until 90 days after delivery, so that we could assess our oral cleft outcomes during this evaluation window. Also, we assessed for oral cleft both in the mothers as well as the infant claims, as well as we considered it to be a valid outcome as long as the 2 codes were observed either in the mother's claim or the infant claim. So this brings me to a point, with regards to assessment of maternal as well as infant outcomes using claims data. So as Liz had mentioned earlier, that infants may not be enrolled at the time of birth. There could be a lag in time between date of birth as well as up to when we observe enrollment for the infant. And we've observed that infants are typically enrolled and they have their own health insurance ID within 30 to 60 days after birth. So before they have their own insurance ID, claims for the infants are usually observed in the mother's claim. So therefore, we would like to assess infant outcomes using both the mother's as well as the infant's records. And if we do plan to assess the infant's outcomes using only infant records, then that would require a limiting to infants that are enrolled at birth. So it could be slightly more restrictive, and we could have a smaller sample size. So now, finally, I would like to kind of wrap up with all of the options that we had specified for the co-primate replication study. So starting with what you see by the blue star, so we first identified all of the live birth deliveries using the mother-infant linkage data, and then we used gestational age codes that were observed within 7 days from the delivery date in order to estimate the pregnancy start. We did require 391 days of continuous enrollment before delivery to ensure that we capture the entire pregnancy episode, as well as we required 90 days of enrollment after delivery in order to assess the oral cleft outcome. We also applied exclusion criteria as well as defined covariates within 90 days around the delivery. And then we defined, exposed and reference cohorts and assessed oral cleft outcomes in the 90 days after delivery. So now that we have selected all of our parameters with our tools, the next step would be to adjust for confounding as well as estimate the association between co-primate as well as oral cleft. So this brings us to the last step in our inferential analysis, that is evaluating the relation between the exposure and the outcome. And before we do that, I would like to walk you all through the order of operations that we employ at Sentinel when we are working with the data partners, and Noelle described this in the first part of the training today. So if you have your own data, these steps may look slightly different, but essentially, when we are running the propensity score analysis, some of the steps are conducted at the data partner side and some are done at Sentinel. starting with the first step, each data partner uses the cohort identification as well as the descriptive analysis to identify the pregnancies of interest, as well as to find the exposed and the reference cohorts based on the criteria that we specify. Then in the next step, the SIDA tool, identifies the covariate information in order to report it in a baseline table or to use them as predictors in the propensity score model. And this is as far as the SIDA tool goes, and then the propensity score analytical tool kicks in. And the first step in the PSA tool is to deduplicate the cohort. So just to remind you all that our cohorts are created based on pregnancies and not patients. So a patient could have had multiple pregnancies, some that are exposed, some that are referenced, and a patient really cannot contribute to both cohorts at the same time. So our tool prioritizes the first exposed pregnancy episode. And once the cohorts have been deduced, then the tool then estimates the propensity scores based on the covariate information that we had extracted, and it controls for confounding using either matching or stratification, and then it generates the output file. So all of these steps that we looked at are run at the data partner site, and the Sentinel does not have access to any of the patient information, and the output files are then returned back to the Sentinel Operations Center by each of the sites. And usually within Sentinel, when we are conducting analysis, we have a multi-site study, so we do have to aggregate the data that's returned from the different sites. And once we do that, we can then generate crude as well as adjusted risk estimates, and then populate or output those all of the results in a nice formatted report, which you see most of our reports, like the format that you see is a standard report that we output using our analytical. So this is, the operation flow that, we kind of follow when we are doing a propensity score analysis. So now I would like to kind of take you all back to how we calculate the propensity score as well as generate effect estimates using our tools. So with our pregnancy tool, we have two options for evaluating the maternal and infant outcomes, depending on whether you're conducting a single outcome analysis or a multiple outcome analysis. And I will be focusing mostly on the single outcome analysis today. So with the single outcome analysis, you can use logistic regression in order to estimate the association between the exposure and the outcome of interest. And just to remind you all again that in pregnancy analysis, the exposure and the outcome is binary, so there's really no time to event. So logistic regression is a good fit. And we can control for confounding using propensity score matching, stratification, or even covariate stratification. If we are interested in assessing multiple outcomes, then TreeScan allows us to detect safety alerts across a wide range of maternal as well as infant outcomes with a single exposure of interest. And I am not going to get into the details of signal detection today, but just noting that that is an option that we also have available with our tools. So in order to control for confounding, based on the characteristics that we've observed, we have to estimate the propensity score. And I'm assuming most of you all are aware how propensity score estimation works. But basically, it's a logistic regression model in itself that consists of the covariates that we would like to include in the model, and it basically predicts the probability of the patient receiving the treatment or the exposure of interest. We may want to consider covariates for inclusion in the propensity score model that are potential confounders, as well as risk factors for the outcomes. Also, we need to consider the prevalence of the covariates because small cell sizes for these covariates may lead to model non-convergence, indicating a poor model structure. So once we've estimated the propensity scores, you can see that every pregnancy, whether it's an exposed or a reference cohort, is going to be assigned a propensity score that's ranging from 0 to 1. And once that step is done, then we control for confounding using either propensity score matching or stratification. So in the co-primate study, we created different propensity score models for each analysis and optimized them in order to retain sample size. And our full model included a range of covariates, including demographics, treatment indications, comorbidities, and lifestyle factors, medication use, as well as the healthcare utilization metrics. Some of our analysis excluded one or more of these covariates in order to keep the analysis-specific propensity score models as parsimonious as possible. So now that we've defined the covariates that we would like to include in the propensity score model, let's discuss how we can control for confounding. And the first option that I mentioned earlier we have available with our pregnancy tools is the propensity score matching. And in propensity score matching, nearest neighbor matching without replacement is being used, and it calculates the difference in the propensity score between the treatment as well as the reference cohort, finds the smallest difference, and it then matches the exposed and the reference cohort, and it removes that matched pair, and then it repeats in cycles. We do have the option to conduct either 1:1 or 1:many variable or fixed ratio matching, and we can specify a caliper fit that's the maximum matching distance to be used for matching. And in the co-primate replication study, we did 1:1 matching with a caliper of 0.05. And also to note that with propensity score matching, whether we are doing 1:1 or 1:many, there is inherent trimming of the distributions that do not have overlap. You can see that in the graph, the tail ends of the propensity score distributions have been trimmed, and we will see how this kind of affects our cohort size when we review the results for the co-primate use case study. Okay, so moving on to the second method that we have available for control of confounding is propensity score stratification. And in propensity score stratification, we group our exposed and reference cohorts into strata defined, by the number of groups that we specify to stratify the, propensity score distribution both for our exposed and reference cohorts. And our tools perform the average treatment effect like analysis as opposed to average treatment effect among the treated. And then similar to the matching, figure that I've shown for the propensity score distribution, you can see in stratification, it basically divides the entire distribution. In this case, we had specified quintiles, so it has kind of, divided the propensity score distribution for the exposed and the reference cohort into quintiles. And this helps retain the entire cohort size. The baseline covariates are approximately similar between the treatment and the comparative group within the same stratum, but it may lack common support if there is poor overlap between the distributions. And higher number of strata improves bias reduction, so it looks closer to matching. And in the co-primate study, again, when I show the results, you will appreciate how the PS stratification retained a much larger cohort size as compared to matching. So once we have, estimated propensity scores using either matching or stratification, then we can move on to the next step, that is estimating our risk estimates for risk of the outcome. And the output that we get with our pregnancy tool will provide us cohort sizes for both the exposed and the reference cohorts before matching, that's in the unmatched analysis, as well as after matching. The number of events that we observe, the crude risk estimates, as well as the adjusted odds ratio that we've estimated for our unmatched, match, as well as stratified logistic regression. And when we are working within Sentinel, we do a disputed analysis, so even our unmatched analysis are still adjusted for sites that contribute the data. So now that I've walked you through, the methods that we can use for confounding, as well as how we can estimate our effect estimates, I would like to bring in back the co-primate study and share some of our findings. So just as a reminder, the Hernandez CF paper that we had used as a use case study for replication conducted two sets of analysis. So for the primary analysis, we compared co-primate to an unexposed cohort. And in this study, they had noted an adjusted risk ratio of 2.90 for oral PrEP, comparing co-primate users during co-primate use during first trimester to those unexposed. And they also conducted an active comparator analysis where they observed an adjusted risk ratio of 2.30, comparing tropramate to lamotrigine use during the first trimester. So let's look at how our findings looked, in the Sentinel analysis. So for our unexposed comparator analysis or the primary analysis, we identified 2007 tropramate exposed and over 1 million unexposed pregnancies. And this was the size of the cohort that was also available for the propensity for stratified analysis. And after matching, we retained 1,980 pregnancies, both for the matched tropramate as well as the unexposed cohort. In the active comparator analysis that's shown on the right, we identified 1,996 tropramate exposed and 2,859 lamotrigine exposed pregnancies. And after matching, we retained 1,131 tropramate and lamotrigine matched cohorts. And just to remind you again that the way our tool works with the propensity score analysis, the first step is to deduplicate the cohorts. And that's why you will see that, the tropramate users are slightly different prior to matching. And this is probably because 11 of the tropramate users had evidence of lamotrigine use in the 90 days prior to pregnancy or the first trimester, and that's why they are not available or they were not included in the active comparator analysis. So these are the histograms for the propensity score distribution comparing the tropramate exposed and unexposed cohort prior to matching. And you can see that the distribution for the unexposed cohort, which is shown by the golden bar, is quite skewed to the left. And after matching, we do see that, I'm sorry, I think I skipped one slide. Okay, and after matching, we do see that the distributions for both the exposed and the unexposed cohorts did overlap. And for our active comparator analysis, we do see that there is variation between the propensity score distribution, both for the tropramate as well as the lamotrigine exposed cohort. And this is likely because of the different, slightly different indications for these drugs. And after matching, we do achieve overlap for the most part between the tropramate and the lamotrigine cohort. So let's look at some of the cohort characteristics that we assessed between exposed and reference cohorts in both of our analysis. So in our unmatched cohort, we did see differences in the covariate distribution between the exposed and the reference cohorts. And these differences varied by analysis. So you can see in the first figure on the left, we found that the tropramate users that's shown by the blue bar were more likely to have depression, anxiety, as well as some of the tropramate indications such as epilepsy or seizures, as well as migraine or bipolar disorder. In our active comparator analysis that's shown on the right, the lamotrigine users were more likely to have epilepsy, anxiety, as well as depression, while the tropramate group that's again shown by the blue bar were more likely to have migraine or bipolar disorder. And once we had conducted matching, we do see that the covariate distribution is quite similar between the cohorts in both of the analysis, although we do see slight variation for migraine or bipolar disorder indications between both of the cohorts. Further, we also looked at demographics, including maternal age at delivery, which for majority of our pregnancies in both of the analysis had delivery between the ages of 21 to 30 years of age. And this distribution kind of retained even after matching. Further, when we looked at preterm as well as post-term delivery codes that were observed, around the delivery date, we noticed that majority of the pregnancies, both, in the exposed and the reference cohorts, did not have evidence of gestational age codes that were observed around the delivery. And when we compared the two analyses, you can see slight differences. So with the unexposed comparator analysis, you can see a higher proportion of the unexposed cohort had post-term delivery codes that were observed around delivery. Whereas, after we had done the matching, we did note that the proportions were kind of similar, but for our active comparator analysis, we still noticed that a higher proportion of the lamotrigine users had both preterm as well as post-term delivery codes that are observed around the delivery date. Further, we also assessed the number of dispensings that are observed both for orthophromate exposure as well as the lamotrigine drug during pregnancy. And we do see that there is a large drop in the topramate dispensing during pregnancy, as you can see how it drops during the second and the third trimester as compared to the lamotrigine. And even after matching, we did observe, the same trend for the dispensings that were observed for topramate compared to the lamotrigine. So now let's look at the results that we observed for oral PrEPs association with topramate exposure. So first, starting with a primary analysis that used an unexposed comparator as our reference cohort, we did observe for our crude analysis an increased risk of oral PrEPs with topramate use as compared to the unexposed cohort. For our 1:1 matched analysis, we noted very few events. As you can see, for our unexposed cohort, we only observed one event, so our estimates are slightly imprecise for the matched analysis. But in the stratified analysis, we did observe that the topramate users were 2.9 times more likely to have an infant with oral PrEP compared to those unexposed. And these estimates were similar to what were observed in the Hernandez-Diaz paper that noted an increased risk of oral PrEP of 2.90 comparing topramate to the unexposed cohort. And this is likely because the Hernandez paper used propensity score weighting instead of matching for control of the confound. So moving on to the results that we observed for our active comparator analysis. So for our food analysis that compared the risk of oral PrEP between topramate and lamotrigine users, we do observe an increased risk, although you will note that across the analysis, we found fewer number of events, so our effect estimates are slightly imprecise. In fact, for our matched analysis, we observed that the risk was kind of was reversed, but I will caution against making any conclusions here given, the small number of events that we observed in our exposed and reference cohorts, as well as the wide confidence intervals that we observed. For our PS stratified analysis, we did note that the topramate users were 2.7 times more likely to have an infant with oral PrEP compared to the lamotrigine used during the first trimester. And again, our estimates for the PS stratified analysis aligned with the Hernandez paper that noted an adjusted risk ratio of 2.4. So these are the main analyses that we observed, both comparing the topramate to the unexposed cohort and the topramate to a lamotrigine, which was an active comparator, and risk of oral PrEP. Now I would like to go to our final conclusions that we made from testing of the use case study, as well as our tool capabilities in general. So similar to the findings of Hernandez CR paper, our replication analysis found an increased risk of oral cleft among infants, comparing tocramate to an unexposed cohort, as well as we also noted an increased risk comparing tocramate to the lamotrigine cohort. Although we did note that a stratification analysis retained a larger size of our cohort than as compared to 1:1 matching, as I mentioned earlier, there were very few events that were noted in our unexposed cohort. So in future, we may choose to employ additional confounding control techniques in order to retain sample size, like do 1:n matching rather than doing 1:1 matching for estimation of the risk of oral cleft. And this was the first time that we tested the capabilities of our tools to estimate the risk of maternal and infant outcomes associated with exposures during pregnancy. And we were able to replicate the published results that corroborated these findings by employing similar but not exactly the same analytical methods that we use in the Hernandez CR paper. And finally, the flexibility of our pregnancy tools allowed us to conduct a variety of analyses using different methods for controlling confounding, including propensity score matching, as well as stratification. And as with any study, there were limitations to our analysis, some that are related to limitations of our tools and some that apply to claims data in general. So our analysis was limited to singleton live-born infants. And as Liz mentioned earlier, that in the mother-infant linked data, we do capture multiple gestations, but our tools were developed only to look at singleton pregnancies. The analysis was limited to pregnancies that had a live birth delivery outcome. And because pregnancies that end in a non-live birth outcome, such as spontaneous abortions or stillbirth, the pregnancy duration is slightly hard to estimate, and we may not be able to accurately classify the timing of the exposure. But we do have methods under development so we can estimate the pregnancy duration in non-pregnancy outcomes such as stillbirth that are currently under development. And finally, as you all know, with health insurance claims data, these are collected for business purposes and not for research. So there can be some misclassification of the exposure, the outcome, or even the covariates. So we would recommend to use validated algorithms for defining the outcomes and also conduct sensitivity analysis in order to assess for misclassification. So how can FDA as well as others leverage, all of the functionalities that we discussed today for a pregnancy tool? So FDA now has access to a large network of 5.1 million linked mother-infant pairs, and this supplements the existing use of the pregnancy registry data. FDA as well as others can use the data that they have formatted in the common data model format and use, if they have available the linked infant data to conduct inferential analysis, assessing the associations of maternal or infant outcomes with pregnancy exposures that are observed during pregnancy. And finally, I would like to just mention some of the analysis that we have completed using the mother-infant linked data. So the first is the co-pyramid use case study that we discussed today, and the SAS analytical package is posted on our website, and the final report should be available soon at the link there. We are also assessing both the maternal as well as the infant characteristics using the mother-infant linkage data, and the findings from the maternal characterization are available on the website, and we are currently exploring the infant characteristics using the mother-infant linked data. And finally, we also have completed a study that estimated the risk of cardiac malformations associated with our modafinil or modafinil use during pregnancy, and more detailed on this project can be accessed at the link that you see here on our website. And finally, I would like to acknowledge all of my colleagues at Sentinel that have heavily contributed to development of this new functionality that we have available for our pregnancy tools. I would like to also thank all of the team members at FDA, and also the data partners that have contributed data to the mother-infant linkage data, which is part of our Sentinel distributed database. So that's all I have. Thank you. And I was not checking time, so Noelle, I'm going to turn it over to you if we do have time available.
Yeah, thank you, Mayura. And actually, I'm going to very quickly cue Yulia to please post the, to put up the post-training survey. So I see that I think that nearly all of the questions have been answered. So I will address the last one as everyone is completing the survey, which will just take a moment. These slides will be posted to the Sentinel website later today, and you'll actually get an email with a link to the location as well. So, and sorry we don't have more time for questions, but luckily Judy has been monitoring all the questions that have been coming in. So thank you, Judy, and thank you to everyone who brought your questions. So hopefully everyone can see the post-session evaluation window on their screen now. It's just a few questions to get a sense of what you thought of this morning's public training. We are just a few minutes before noon, so thank you to everyone who's completed the final evaluation so far and for attending today. If you have any lingering questions, please put them into the chat box, and if we don't get a chance to respond in the next few minutes, we'll do our best to send you a message, or you can certainly also send us emails as well. I see there is a question about the length of time it takes to conduct a pregnancy analysis in Sentinel. It's a difficult question to answer because there's actually a number of factors that come into play. Quite frankly, the longest aspect of our work is often specifying the explicit analysis that we want to conduct. And that's really about epidemiologists within the Operations Center and FDA coming together and making a lot of decisions. So as Judy said, she's getting to the point basically that if the person asking the question can quickly specify exactly how the parameters should be defined, then we can turn it around an analysis in really 6 to 8 weeks or so, based on sending the package to the data partners and then running it and returning it. There's testing involved. So it's not an overnight thing, but it's really quite quick. We've got another couple minutes. If anyone has additional questions or comments, please let us know. What is the progress of adding other pregnancy outcomes? So I will let others address that. There have been some comments around stillbirth in particular, or questions earlier, and we do have ongoing work in that area. So I don't know if Judy or Mayura want to address that question in the last couple minutes that we have, but there are also links within the chat that are referring to that work.
Sure, Noelle, I can address that. So we do have an ongoing stillbirth validation study where we are validating ICD-10 codes that we are using to define stillbirth outcome. I think Judy did share earlier on the chat, some of our preliminary results that we had presented at ICPE this year, so you could access them on our website. And we should have final results from our validated algorithm, available on the Sentinel website pretty soon. I'm also going to mention that we have also conducted, with FDA, estimating gestational age using prenatal tests, both among the live births and the stillbirths. So that also has been posted on the website, and we are currently working on a manuscript in order to publish our findings. So both of these have been posted on the website, and we can access them.
Great, thanks, Mayura. And thanks again, everyone. We've got just a minute before noon, so I think that a large majority of people have responded to the evaluation, which we appreciate. And feel free to send us any questions or comments afterwards through the Sentinel website. So thanks very much, and hope everyone enjoyed the annual public training this year, and hope everyone is doing well, and that we'll see you again soon. Thanks so much.